And our students are Dr. Arul Raj and Murakam Sen from Bhubaneswar. So, welcome to you all, guys, and I hope we will have a very interesting session today. Thank you, Ziba. Over to you.
Hi, Rohit and Arvind Bhai.
Hi, Rudra. How are you?
Good.
Ziba, have you started the class? And are we live?
Yes,
They will
sir.
start. They will start. Yeah.
So we have two cases today. So one is the most common one. That is the thyroid nodule that we see.
You can share your screen. Yeah, thank
So
you, sir.
this, yeah. Uh, yeah.
What is going on?
So Dr. Arul, can you start your case, please? You are dealing with the first case, that is the thyroid nodule.
Um, 1 minute. What is going on? Okay. One moment, sir. Your presentation is downloaded, sir. Can you share your presentation?
I think I've sent that presentation to you, and if you can
I'll do that. I'll do
share
that.
with the students, yeah, so they can evaluate and then start working on it.
Okay. So this is the first case prepared by Rohit, sir. Sir, whatever questions you want to ask, I'll just move on to the next slides. Even you, sir, Arvind, sir. This is the case of a 33-year-old female, a resident of Mizoram, and she is a homemaker.
Right. Yeah, maybe the first we can start by saying that,
Please, yeah. So
maybe
she's
there are two relevant things over here. One is the age and one is the gender. Maybe I would just ask you all to sort of, your thoughts about this, age and gender, and maybe because this masterclass is about thyroid, so obviously I think you can just talk. What do you really understand by sorry, what
one.
do you understand by age and thyroid cancer?
So, sir, we will address the questions to each of the candidates by name so we can move along this process faster. And candidates, if you don't know any answers to any questions, you can say that you pass, and the examiners will provide you with the ideal answer. And for the other participants who are there online, there is a Q&A section. You can post your questions in the Q&A section, and we will try to answer your questions either during the presentation or at the end of all the presentations. So I think we can start with Dr. Arul Raj. Sir was asking what is the relevance of age and sex in pertaining to thyroid tumors.
Thyroid cancer will be more in females compared to males, ma'am.
Perfect. Agree. Very good. One point. Bharat, can you make any other point? So one is the predilection, it is more commonly associated. What else?
Dr. Mukarram, do you have anything to add to this?
Yes, ma'am. One is, as he said, female predilection, and she is a middle-aged female. So,
Yeah, anything with age and anything with gender. Now, what do you understand?
uh,
So is there any implication at all? One, you said that the association is there. Women are more prone for, in terms of numbers, is more. Anything else in terms of, say, a prognosis, anything with age, What do you really understand by these?
Sir, younger age group can be associated with hereditary disorders, and
Okay.
she being a middle-aged female, we can think of in terms of follicular neoplasm.
What do you understand by younger age?
Dr. Mukarram, she's just 33 years of age.
Yes,
No,
sir.
that's fine. That's fine. Yeah, I think she might be young only, I guess. But I just wanted to understand because see, in science, no, you have to objectively. So there is something called as a there's something called as a pediatric thyroid cancers. Are you aware uh, of that, Dr. Makram or Dr. Arul Raj? So yeah, anything less than 18 years or so is that. So anything with age, specifically with regards to thyroid cancer.
Sir,
Sir,
elderly age group, lymphoma is more common, sir.
more
And
than
in
55 years and less than 55 years, there is a cutoff that even with metastasis less than 55 years, cancer
Correct,
will
correct.
stage.
So
The
thyroid
prognosis, yeah.
is one of the cancers in which age is prognostic. Initially, the age cutoff was 45. Now
However,
with AJCC 8, it is around 55 years. So
five
if it
years.
is 33, I mean, just in the interest of time, like, so if it is she's 33-year-old, that means she falls under the
Less
slightly
than 55.
better prognosis. Of course, and women in generally tend,
have
although stage
better
for
prognosis
stage
than males.
men, they don't really have uh, any better prognosis, but by and large, because of smaller tumors, they tend to have better prognosis. Yeah, we can proceed. I think a lot of time has been spent in this itself, but there are more to this as well, but I guess you guys can read it. In the interest of time, we'll proceed. Yes, Dr. Nair, you can proceed, sir.
So she presented with a swelling in front of the neck for 6 years. And about 6 years back, she was all right, but she noticed the swelling during her second pregnancy. It was insidious and increasing in size, more on the right side. And so, yeah, what are your thoughts on this, Dr. Arul?
During pregnancy period, there will be a need of increased thyroxine hormone, which leads to excessive hormone production, might be lead to any thyroid swelling, ma'am.
Do you want to add anything, Dr. Mukarram?
Uh, yes, ma'am.
But
The
why
same.
is it just increasing on the right side, insidious in onset, gradually increasing? So, Dr. Arul, you said there is increased need for thyroid hormone. So there is increase in size. How often do you find that as a regular finding in pregnant women?
Rare.
And what are your differential diagnosis?
So most likely they are physiological, where during pregnancy you see these thyroid gland enlargement. So you think more towards being a benign lesion rather than you're thinking towards a malignant one. So these are the main historical features. When you are taking history, that's how you keep making inferences on diagnosing a lesion.
Right. Any association with estrogen and thyroid cancer?
Dr. Mukarram,
Anyways,
you want
Dr.
to take
Arul
that?
Raj, or
Sir,
no, yeah.
uh, estrogen
No,
and
why is it more common in women? Is it to do with any hormonal changes?
Dr.
Please, Dr.
Arul,
Arul
do you
Raj.
have any idea
Do you
why?
have an answer for this? Otherwise, we can. No, there is an association with estrogen. So I think we can discuss that later. Dr. Nair, I think we can proceed on this. So please read up. There is an association of estrogen, and that is one of the reasons why women tend to have a higher predilection to get thyroid cancers.
So, according to the history which Sir has gathered, there's no association with any pain or any change in voice, no history of any dysphagia or dyspnea, no history suggestive of hyper or hypothyroidism. So, can we club together all the negative history and see what exactly clinically we are trying to rule out? What is with the first negative history? No history of any pain associated. What kind of swellings in front of the neck are associated with pain and or any change in voice?
Pain
Dr.
can
Mukaran?
be pain can be because of any infective etiology, ma'am, like thyroiditis, and change in voice
So
can be
we should
because
mainly name it inflammatory.
Inflammatory.
Okay,
inflammatory.
inflammatory, because infection means it gives a different connotation.
Inflammatory
Yeah, yeah.
swellings, like thyroiditis, and change in voice if it is
No, can pain be associated with malignancy,
yes, sir.
Dr. Mukaram?
Yes, sir. If
Yep,
it is locally infiltrative and advanced malignancy, pain can be there, sir. But
correct,
since
correct.
this
So
is
any
indolent
sign of
and
local infiltration, there could be associated pain. And again, come to change of voice quickly.
change of voice also can be because if it is locally infiltrative tumor, then it can cause change in voice, sir. In this case, there is no change in voice. This is a slow growing malignancy problem, slow growing tumor probably, sir.
Probably, no, it's around 6 years back, no? So
6 years.
it is like, yeah.
Yeah.
So it's been a long history,
Yes, sir.
and yeah.
Why do you think we have asked for any history of dysphagia or dyspnea?
Due to compressive symptoms over trachea and esophagus may lead to dysphagia and dyspnea, ma'am.
Okay.
Okay.
Correct.
And I'm sure you know the feature suggestive of hyper and hypothyroidism in detail. So we will not dwell on that. And no history suggestive of any distant
So,
metastasis.
just coming to that question, just to complete it, and
Right, sir.
generally in thyroid cancers, what is the thyroidism that you see? Do you see hyper, hypo, or euthyroidism?
Yeah.
Either
More
hypo or
commonly.
Hypo or euthyroid, sir, but not
Euthyroid.
hyper
Yeah.
in
Okay, so
general.
most commonly they are euthyroid.
Thyroids. Yeah.
Rarely they can be. Can it be hyper also?
mostly hyperthyroid will not be associated with malignancies.
Correct. But
Yes.
can it be? Can have
If we
do
do
you have you all
radiography,
seen any time in your because thyroid, as Dr. Sharad said, like it's some very common things, right? From MBBS, MS, and all, we all keep seeing this, no? So have you all come across, by any chance, any association, any thyroid cancer with hyperthyroidism?
No, sir.
Arul, can it occur?
yes, sir, it can occur, sir.
It can occur, sir, but I think it
It
is
can.
very rare
It is
It
that we
can
come
occur.
rare.
across
It can.
till now.
Correct. But we have come across a couple of cases. It's rare, but it can occur. Yeah, go ahead. We can proceed. Yeah.
So we proceed to the general clinical examination. The patient was examined in a well-lit room after obtaining proper consent. She was conscious, oriented, and cooperative. Afebrile. Heart rate is 72 beats per minute. It was regular, normal rhythm with adequate volume. A blood pressure of 124 by 80 millimeters of mercury in right arm supine position, and a respiratory rate of 16. No pallor icterus cyanosis clubbing, pedal edema. So, starting with Dr. Arul Raj, what are the key clinical findings in your general examination that you are looking for while you're examining someone with swelling in front of the neck, which you have reduced to be a thyroid swelling?
To look for any hypo or hyperthyroid features, ma'am.
Anything in this list of details which sir has provided, what are the abnormalities that you're looking for? Right now here everything is normal.
BMI probably in hypothyroid case will be high and in hyperthyroid it will be less. But here it is everything is normal and pulse rate it's normal also. Other than that, there's no abnormality not
Okay,
found here.
Dr. Mukarram, anything else in the heart rate?
Uh, Pulse rate, tachycardia, tachycardia, and high volume pulse will be there in hyperthyroidism, and then again moist palms also can be seen in general examination.
Yeah.
Maybe irregular rhythm will be there and
Irregular.
That's to differentiate between your toxic and the hypothyroid and the euthyroid. So this suggests of more of a euthyroid state.
Correct.
Okay, so can we move to the next slide? Yeah.
Yeah.
This is general. Is history of radiation important in these patients?
Yes, sir.
So why it is important? History of radiotherapy. Does it have any implications?
If ultrasound shows any nodule, if it is a normal patient, we will intervene only if it is more than 1 centimeter. But if it's a irradiated patient, we have to go and look for, we have to go and do an FNAC irrespective of any size, sir.
Correct. And previous thyroid surgery?
Dr. Mukarram, you want to take that?
Yes, ma'am. History of irradiation is suggestive of pointing towards papillary thyroid carcinoma. So that is important in the past history. And
Now, what radiation would contribute to thyroid cancer? What sort of radiation? For which cancers would they radiate?
Hodgkin's disease, sir, in the childhood, neck irradiation for Hodgkin's disease.
What is a
Lymphoma.
Lymphoma, sir.
See, that was something that they used to do much prior, but now with the advent of a lot of effective systemic therapies, the role of mediastinal. Are you aware of that field of radiation which they used to give
Mantle.
for lymphomas? Yeah,
mantle irradiation.
So what is the amount of radiation would the thyroid receive?
I'm not sure, sir.
Low dose, high dose. No, I'm not asking you exact dose. It's not a radiotherapy exam. I know that, but anything to do with the low dose or high dose, like what will happen with the dosages? Do you think low dose is more riskier or higher dose?
Higher dose will be better, sir. Low dose, higher dose, the follicles will be destroyed, sir. But in low dose, it might lead to some mutational changes, might be causing some cancer in the future.
Very good. Very good. So what happens is in the mantle field, so some amount of scatter or low dose radiation therapy would have been received by the thyroid gland, which sort of, as Arul Raj, you rightly said, that it could potentiate. So there is a latent period. What is the latent period for developing a thyroid cancer after radiation?
15 to 20 years, sir.
Very good. 15 to 20 years. And so, as you rightly said, high dose radiation would sort of destroy the follicles, and so the chances are less. Vis-a-vis radio iod, say, or maybe nuclear fallout. If there's a nuclear fallout, so thyroid cancers do occur, right?
Yes.
Yes, sir.
When a nuclear. So what is the difference between a thyroid cancer occurring because of a nuclear fallout and because of radiation therapy, in terms of latent period and all? This is more of the general knowledge and curiosity, but these are all quite interesting perspectives also. You all can read, like, post Chernobyl, which is the most sort of talked about event of a nuclear fallout. Of course, there have been other nuclear fallouts as well after that. When did the first thyroid cancer occur after Chernobyl incident? Approximately. So generally very less. The latent period, as you rightly said, for radiation therapy would be anywhere between 15 to 20 years. But after a nuclear fallout, even within a short period of time, you can have the thyroid cancer. This is more of the general knowledge, but it is important. If you are treating a thyroid cancer, possibly in Russia or in many other places, it's important to sort of know about these, especially if they have been exposed to a nuclear fallout at that particular point of time. Okay. Right. Yeah, we'll go ahead.
Yeah. So we had no history of any thyroid or head and neck malignancy or Men's syndrome in the family. Dr. Arul Raj, do you want to start with what all family history are you looking for in a case of thyroid swelling?
Certain syndromes which are associated with the thyroid cancer, ma'am. FAP, Cowden syndrome, Carney's complex. And then
Do you know
familial non-medullary thyroid cancer, papillary renal cell aplasia, papillary renal hyperplasia.
So you don't know whether it is differentiated or non-differentiated thyroid. It's a thyroid lesion. So can medullary cancers can happen?
So these are all mostly associated with differentiated thyroid cancer.
Yes. So differentiated, or it could be medullary also. So when you are asking for a family history, you need to take care of all the syndromes where you can have a thyroid malignancy, irrespective of because we don't know whether it is well differentiated or not right now. We are just
Correct.
looking at a patient with a thyroid swelling. Correct? So it could be anything. It could be anything. It could be benign, it could be malignant, it could be well differentiated, it could be medullary. So you don't know that. So you have, for a family history, you have to look for all those thyroid cancer symptoms where you can have thyroid malignancies.
Yes.
Correct.
Okay. So we'll quickly move to the next slide now. So you understand the history, the family history part. So this is the personal history. So
Anything in particular you're looking at
yeah.
in the personal history, Dr. Mukarram?
Personal history, ma'am. When we are trying to rule out the symptoms of hypo and hyper, in this decreased and increased sleep can be there, ma'am. And in bowel and bladder habits, in certain patients of hyperthyroidism, there can be diarrhea and menstruation. And here, cycles are regular, but with respect to hypo and hyper, there will be menstrual irregularities. Specifically in hypothyroidism, there will be menorrhagia, polymenorrhea, and hyper, there will be oligomenorrhea. All these things we can come to know from the personal history.
Okay.
Got it.
Right.
Very
Yeah. So even briefly, the diet is also important. You need to know that patient is not completely dependent on a vegetarian diet involving just cabbages or something like that. You need to know a little bit about the diet and quickly moving on to the next. Coming to the local examination, starting with inspection. First of all, candidates, Dr. Arul, what is your preferred position of examining the patient? What is the position of the patient? What is the position of the exam?
Sitting position with neck slightly extended and standing in front of the patient for inspection, ma'am. For palpation, we have to stand behind the patient.
Okay. Okay. So, patient is, like you said, sitting and with neck slightly extended. A swelling is noted on the right side of the neck, about 4 by 4 centimeter, extending laterally up to the right sternocleidomastoid muscle, around 3 centimeters from the midline, and inferiorly 1 centimeter above the suprasternal notch. It has a smooth surface with globular shape. Margins are well defined. It moves with deglutition but not with protrusion of tongue. The lower border is visible. Skin is normal and there are no engorged veins or visible pulsations. So, what are any thoughts on the findings of local examination inspection? Looks like a very smooth swelling which is maintaining its distance above the suprasternal notch. Anything you want to add, Dr. Arul? What is the importance of something in the front of the neck which moves with deglutition but not with protrusion of the tongue?
Thyroid swelling and thyroglossal cyst and laryngocele could move with deglutition, ma'am. There are swellings that will not move with protrusion of tongue.
Come again, Arul.
Sir, thyroid swelling with move with deglutition, sir.
Correct.
Thyroglossal cyst will move with both deglutition and with
Okay.
protrusion of tongue,
Got
sir.
it. Got it. Now, yeah, now you're clear.
Yeah,
Earlier
even
you
I
tried to
got a little
confuse
confused.
everybody. But fine. But
Other
see,
swellings like
yeah, these are elementary things, but but you often tend to get asked, and you should sort of not get overtly confused during examinations and all those things. Yeah.
these are
Dr. Mukram, you're adding something.
other swellings also, sir, like prelaryngeal lymph nodes, pretracheal lymph nodes, avoid bursitis, all those things also they move with deglutition. Just to
Okay.
add
Right.
on this.
Correct. Yeah.
So coming to the palpation
anything
quickly.
with the suprasternal notch. So is it important to mention that? or not?
Yes, sir.
For retrosternal.
Suprasternal notch, if there is retrosternal prolongation, then we'll not be able to find the lower border. We'll not be able to
Yes.
it won't be
So,
palpable.
yeah. So clinically, you can make out that this is a lesion which is confined to the neck, and there is no retrosternal extension of the lesion. So all these informations are available clinically. So a good clinical examination is what will tell you more than 80% of the information required.
Right.
So now on
So
palpation.
coming to the palpation, the findings were confirmed. The swelling is palpable in front and the right side of the neck, predominantly around 4 by 4 centimeters. There is no local rise of temperature and there is no tenderness. It is firm in consistency with smooth surface and regular margins. The isthmus is palpable and the lower border is also palpable. There is no retrosternal exchange. It is non-pulsatile and it is not fixed to the overlying skin or underlying structures. Moves with deglutition. The trachea is central. The carotid pulse is in the normal position and there is no cervical lymph node palpable. So coming to Dr. Arul Raj, the examiners, can you ask specific questions to the examinees?
Seems to be a pretty straightforward case, no? For you also sort of,
Yeah, it's
yeah,
all there.
but I get it is important that you sort of tell all the points, and of course I think your palpation things are also sort of more or less similar because the swelling was moving, right? So I guess all the other things have been
Yeah.
there.
So,
Anything specifically you all want to add? Otherwise, we can move on.
so I think moving on, sir has mentioned some special tests. Can you both take chances and describe to us what these tests
Yes,
are
ma'am.
and what is the significance?
Pemberton sign negative, ma'am. This we'll check by asking the patient to raise hands above the head, and if there is facial puffiness, congestion, it will be indicative of retrosternal extension, ma'am. So in this case, this is negative, so there is no retrosternal prolongation. And Cocker's test is uh,
Prominence of sternocleidomastoid on the side of lesion.
Okay, right. And the resident note over Manubrium sterni only signifies there is no retrosternal extension. Moving on, systemic examination largely is normal. So, sir went ahead and did an ultrasound of the neck. We found that there is a solid nodule about 3 by 2 by 4 centimeter TR4. What is TR4?
Thyroid's scoring, ma'am. It
Right.
is Thyroid's 4 is
Moderately.
moderately suspicious lesion.
Okay, so now there is one moderately suspicious lesion in the right lobe of the thyroid. There are a few small cystic areas within it and hyperechoic solid nodule measuring 1.4 by 1 centimeter and 9 by 6 millimeter in the upper third of right lobe of thyroid, which is TR3. Another lesion is noted in the right lobe of thyroid, also TR3. Another isoechoic solid nodule, 7 by 4 millimeters, in the junction between the left lobe and the isthmus, TR4. And an irregularly marginated, mildly hypoechoic and mildly coarsened ecotexture with increased vascularity, no evidence of retrosternal extension. So, what is your inference from this ultrasound report?
More than that, hypoechoic nodule, there is one Thyroid spore lesion 7 cross 4 mm, which looks like malignant with irregular marginated with hypoechoic increased vascularity, ma'am. So while doing FNAC, more than targeting the lesion with largest size, we have to target the lesion with more futures towards pointing towards malignancy.
Both are TR4, but no, there is a 3 centimeter, 4 centimeter lesion and there is a 7 mm lesion. What are you more likely to hit during an FNA?
We can easily hit the 3 cross 4 centimeter lesion, ma'am, but it is hyperechoic.
Right.
It is ISO to hyperechoic, and the other one is an isoechoic solid.
So in terms of echogenicity and malignancy?
Hypoechoic nodule will be more of a malignant nodule.
Right. Okay. So that is why, even though it is a sub-centimeter one, you wanted to target that,
Yes,
But
sir.
then again, as you say, there are about 5 components of thyroids, like, so I guess in the other components, that nodule was also thyroids 4. So I guess, you can, but if there are multiple nodules, right, Dr. Arul Raj,
Nice.
if there are multiple nodules, which of these nodules which you'll try to hit? Will you target the 3 centimeter one, or would you target the 7 millimeter one also? Either, buddy. Dr. Makram, you are keen to
Sir,
take it.
if multiple nodules are there, we have to take FNAC from multiple nodules, sir, based
How
on
many? If
sonographic
there are
features.
10 nodules,
Based on sonographic features, sir, which is more suggestive towards
very good.
malignancy, according to this thyroids, like hypoechoic and which are more suggestive based on
So,
those five
so
characteristics of
what would you
thyroids.
do in this patient?
In this
I mean,
patient, I'll
because
take it from both the lesions, sir.
both the lesions. Okay, fine.
Is
So I
your
guess, if there
management
are, yeah, go ahead, go ahead. If there are multiple lesions which are suspicious as well, so I think it's important that you hit both the lesions. But then if it were only a 7 millimeter pterygids 4, then no other lesion then?
Sir,
If it was only a 7 millimeter pterygids 4,
sir,
no
still,
other lesion.
but the
Still,
other features might pointing towards more of malignancy, so irregular margin, hypoechoic, and this
Yeah,
vascularity.
but Dr. Arul Raj, you only said, like, radiation therapy and all those things, even though it is
Then
sub-centimeter,
one
you'll hit.
centimeter.
And now you are turning your thing. Huh?
sir,
I'm
according
quoting you
to
only. I'm listening intently to each of whatever you are saying, and that's what examiners normally do. So whenever you are emphatically making one statement,
Yes.
now you are sort of contradicting your own statement, like,
Sir, if this 7.2 into 4.6 is the only nodule, then if it is a thyroid for FNAC, we would not do FNAC, sir, because we can do just surveillance.
Right.
Yeah.
Okay, we will come to that later. Essentially, of
Yeah.
course, it is a tricky situation. We will come to that. I have some slides during my talk. I can possibly elucidate that during that course of the talk. Yeah, go ahead.
is your
So, do we have?
management likely to change if you can you see the location of both the nodules? All these nodules are tier 4 large one, the tier 3s are in the right lobe. What is that small tier 4 lesion doing? Where is it? Is your management likely to change?
Yes, ma'am. Because it is lying at the junction of left lobe and isthmus, uh, this patient would go for total thyroidectomy because multiple nodules and it is involving the other lobe also. So surgical management would change, ma'am, by this ultrasound
Yeah,
report.
but you don't have the FNAC report till now.
Yes, sir. I mean, based on this,
So would you or would you not want to take the FNA from that lesion is what I'm trying to ask. Anyway, moving on. Guided FNA was taken from the right nodule, done outside, and features are consistent with colloid goiter. What would you do?
I would go and repeat the FNAC, ma'am.
Right?
We are probably not sure from which nodule they would have taken the FNAC, sir.
Hmm. Yeah,
And
Can you see the
they are
entire report?
So,
it's a guided FNAC, right?
and it has been done twice. So first FNAC was done outside, which is again guided, shows colloid. Then again the repeat FNAC was done, and again it showed a colloid guide.
sir, after the second time, I will not go, sir. But after the first time they have done outside, na, I will do it in our setting with my radiologist.
Very good, very good. Yeah, that's
ma'am,
fine.
in
That's
this
fine.
case,
No,
Yes, go ahead,
go ahead,
Dr.
go
Param,
ahead,
hemorrhagic
doctor.
fluid is there and colloid is not noted. So I think if FNAC is inconclusive, we can go for biopsy to rule out medullary uh,
Huh?
because
Medullary.
no colloid noted is there in the.
Yeah, but still the diagnosis is maybe the second FNAC is suggestive of colloid, no?
Yeah, this is the second FNAC, which is consistent with colloid goiter. So we have a benign nodular hyperplasia as a diagnosis. Anything else you want to do, or you're just going to rely on FNAC, directly go and put a needle in the thyroid?
Uh, uh, Imaging, contrast enhanced CT scan.
Imaging, contrast enhanced CT scan.
No,
CCT
I
scan,
think
definitely.
both of you just want to have a cancer diagnosis. Looks like, So you're all, you just take it, no? Dr. Nair is saying that, in their outside center, in their center, twice it was done. It was a colloid nodule. Why don't you sort of
Colloid
take this
goiter,
information as such? Yeah.
So see, at the end of so many discussions, it's been a swelling which has been slowly increasing for last 6 years, and then now you have a Thyroid's 4 lesion in 2 places, and FNAC is benign in both twice it's been done, and again there's no malignancy in that. So what else will you do now? Is there any blood
And he
test, any
wanted to do a,
investigation, anything
Dr.
else would you
I
like to
wanted
do?
to do a CT scan. Dr. Mukram wanted to do a CT scan.
Contrast enhanced, anything in particular you want to be on the lookout for a contrast enhanced CT scan for thyroid? And what is the particular indication for doing contrast enhanced CT scan of thyroid?
if if I'm suspecting extrathyroidal extension or
There are very specific
nodal,
indications.
yes,
invasion of trachea,
extrathyroidal extension, extensive nodal disease.
intrathecal extension, and if we suspect any mediastinal lymphadenopathy or retropharyngeal nodes or parapharyngeal nodes,
Or invasion into trachea or esophagus.
Invading
So
into
any
trachea,
of
larynx,
these present in your
esophagus.
examination?
I'll go and
No,
do
ma'am.
CCT, ma'am. Here,
Okay.
there is no need for CCT as per the findings, ma'am.
Dr. Aral Raj, how can you know clinically there's a retropharyngeal node or a parapharyngeal node? You say if there's a retropharyngeal node, I'll do a CT scan.
If we suspect any parapharyngeal retropharyngeal nodes, sir. Clinically, if, previously we used to do percussion over sternum to look for mediastinal nodes, sir, upper mediastinal nodes.
Okay. No, the upper mediastinum is fine. But what about you're saying retropharyngeal and all those things?
If there is any other suspicious nodes or other places, we have to go on for CT to look for any retropharyngeal or
Let me
parapharyngeal.
tell you, on the contrary, if you do CT scan only, you will get to know some of these nodes essentially. It is not that you have a suspicion of these nodes and you do a CT scan or something of that sort.
Yes.
You can have parapharyngeal, you can have retropharyngeal nodes in thyroid cancers as well. So I'm not denying that fact, but it is not something that you can clinically suspect and you do. That's my larger point. Yeah.
So since neither of you mentioned, sir has gone ahead and done some basic blood investigations. Anything you want to conclude with this? Mukarram? Patient is euthyroid. Okay. The anti-TPO antibodies are raised and the anti-TG antibodies are raised. Why? First of all, why do both?
Anti-TPO antibodies uh, will be
What is this
raised in
suggesting?
Hashimoto's thyroiditis. It will be raised anti-TPO
Okay.
antibodies. And
So, sir has gone ahead and done a right hemithyroidectomy because everything was pointing towards something really benign. Now, uh, the final histopathology is showing papillary thyroid carcinoma, about 5.8 by 2.5 centimeters, confined to the right lobe. There is capsular invasion only, no lymphovascular or perineural invasion, necrosis, or significant mitotic activity seen. Resection margins are free. The closest margin is less than 0.1 centimeter. Another two microscopic foci of carcinoma are present, 0.6 centimeter, conventional papillary carcinoma in the right lobe, and a 0.3 centimeter follicular variant in the isthmus, confirming multicentric disease. though 4 lymph nodes were also sampled in the process and they were negative. Pathologically be T3A and 0. So any questions for our examinees, or should I proceed to the next presentation?
So what will you do now with this report in your hand?
The lesion size is more than 4 centimeter, multifocal with micro invasion and 0.1 mm close margin. I would go and do a completion thyroidectomy.
Fantastic. Agreed.
Dr. Mukarram has
Yes,
anything
sir.
else to say? She's a 33-year-old young female.
Sir,
And your opposite lobe is normal on ultrasound.
sir, I
Does
would,
she has, do you have any other option? Does she has any other option?
no, sir, I would also like to go with the completion thyroidectomy in this case because of multicentric disease and T3As.
So size and multicentricity are the two adverse factors in this patient, correct?
Yes, yes, sir.
And okay, good. If she says, I don't want a surgery, I don't want another surgery, I'm happy with what it is, can you
Yeah,
allow her to go like that?
yeah. Sometimes what happens is maybe if she has got if she's hoarse after the first surgery, like there is inadvertently there is a palsy, and then she's young and she sort of says like I don't want. No? No, I know both of you all sort of are pushing for completion, which I also agree. Like by and large, I readily agreed with both of your thing. But in real world, sometimes
Yes.
it might happen. No? Some surgeon would have operated at a distant place. The patient, young lady comes. No, so what are your thoughts? Like, I just want, because there are many ways to skin a cat from this from now on.
Like
So
explain the
just want to
about the
understand your thoughts.
recurrence, sir. And if she is willing, I will keep her on follow up with thyroxine supplementation and periodic ultrasound.
Do you need
Okay.
thyroxine supplementation?
Suppression dose. Thyroxine suppression with periodic ultrasound to detect any early recurrence. And if it
Eh,
comes, we can go in and
Any other options that
radioremnant ablation can
can
then,
give? Can you give?
sir, but
How,
if it,
how do you prepare a patient for radioiodine ablation?
uh, the target is
For,
to be more than 30 mm. So we have to keep the patient with withhold iodine diet for 4 weeks and thyroxine for 6 weeks to achieve our target TSH for more than 30 mm. Or else we can give a recombinant TSH.
So you want to
Right.
suppress the thyroxine production, right? You've not completed the thyroid surgery. The left lobe is still there. Can you give the ablation? Is what sir is asking.
in this case, radioiodine ablation is not an option, ma'am,
Right.
because
The entire
we haven't done total thyroidectomy.
Right.
So we have to keep on close observation and follow up, and try to consult the patient regarding total thyroidectomy if feasible.
Right. Right.
Right. Okay.
Anyway, I think so.
Yeah.
I must tell you, like maybe there is a concept called lobar ablation, but I don't really want to confuse you all at this particular point of time. That's probably for yeah,
injection can be done.
for an MCH head and neck or any other sort of examination. We'll leave it at that. But then there is some evidence towards that as well. I think we leave it at that. Maybe we can proceed to case 2, if it's
Yes.
okay, Dr. Nair. And
Yeah. Please go ahead. So we're
yeah,
short of time
because
now.
we are short time, so we can
Yeah.
quickly finish that.
So this is another resident of Mizoram. He's 59 years male, currently unemployed. Okay. He has progressive bilateral lower limb weakness for the past 1.5 to 2 months. There is bone pain since 1.5 months. Apparently asymptomatic 2 months back, gradually progressive weakness of both lower limbs associated with difficulty in walking, performing daily activities, and difficulty in micturition. There is history of backache and bilateral lower limb pain. No history of dysphagia, stridor, voice change, respiratory distress. No history suggestive of hypo or hyperthyroidism. No systemic complaints except bone pain. There's no history of any lump or palpable swelling anywhere in the body. So someone with a bilateral lower limb pain, unlikely to come to you as a primary caregiver, has been referred from somewhere. Someone has already run a CT chest, abdomen, pelvis. There are multiple skeletal mets of unknown primary. In the CT brain, there is an expansile osteolytic lesion with enhancing component, destruction of both inner and outer tables of the right parietal bone, and no extension in brain parenchyma. Initially, patient was managed outside, a craniectomy was done, underwent right cranial bone excision and cranioplasty. The bone histopath and IHC was suggestive of CK7 TTF1 PAX8 positive, I think, and thyroglobulin was positive. So metastatic carcinoma, possibly of follicular carcinoma of thyroid, was reached. Now, patient has come to an institute. Spine fixation was done in 2005 with some screws in situ, but there is no documentation and there is no family history. Coming to the general examination, patient was largely normal. The general examination was on the normal side. Local examination of the neck was done. There is no visible lump or swelling in the neck. The trachea is central, absolutely normal. Pemberton sign is negative. On palpation, there is a small lump about 1 by 2 centimeter over the right side of the neck. It is non-tender. It is hard with regular margins. It is mobile, but not adherent to overlying skin or underlying structures. There is movement with deglutition. There is no movement with tongue protrusion, lower border palpable, trachea central, carotid palpable, and no nodes. So we are dealing with a nodule in the right lobe of thyroid. Hard inconsistency this time, and it is not firm like the last case. Your thoughts, Dr. Arulraj?
Given with the findings and history, it could be a follicular carcinoma of thyroid with multiple bone metastasis, ma'am.
Okay.
Correct.
Systemic examination. So for such cases, you have to complete the neurological examination. Unfortunately, we are short on time and we cannot go into the details. It's pertinent that you know all the aspects of neurological examination. So we have gone ahead.
Just a minute.
Yes,
Is
sir.
neurological examination important for your decision making? What is to be done for management of these patients?
If there is any progressive lower limb weakness due to spine, we will go for fixation.
Correct.
Okay. Correct. Very good. So we just go ahead with the investigations. We go ahead with the case quickly now. So these were the tests which were done.
Yeah.
Ah.
So a very low grade FDG avid lesion with peripheral foci of calcification in the left lobe of thyroid, measuring 1.5 by 1.6 by 2.3 centimeters is noted. It buds the strap muscles anteriorly. Fat planes with left IJV and common carotid artery is preserved. And non-avid calcified nodules in the right lobe, about 1.7 by 1.5 centimeter noted. Low-grade FDG avid lytic lesions in the soft tissue with soft tissue component noted in various skeletal places. Yeah.
So you have to note one thing. He's got a lesion in the C6 vertebra with collapse. Is it significant?
Patient may go for paralysis, sir.
So not paraparesis. So what is more important? So he's got a metastatic thyroid disease with multiple bone mats. Okay.
Yes.
And E6 vertebra is compressed and collapsed.
Yes, sir.
So whatever treatment normally you plan for a metastatic thyroid, what
Just
treatment
in
will
this
you
case,
follow?
spine fixation should be done, sir, to prevent the further worsening of the weakness and paraparesis.
Immobilization patient
So
with the
Then,
steroid.
what do you expect? Like when you are taking this patient for surgery, what precautions will you take in such type of patients?
So first we have to advise immobilization, sir.
sir,
We have to start the dose of steroids and either zoledronic acid or some sort of
Right.
denosumab.
So what precautions will you take?
we'll avoid neck extension, sir. We'll
Correct. Very good.
and
Very good.
start on steroids, as I said, dexamethasone.
Yeah, so once you are taking them for total thyroidectomy surgeries, you have to be very careful that there should not be any pressure or any extension or anything on you have to be careful in handling his neck. That's
Yes.
very, very important. You have to keep some support behind the neck when you are just putting patient down for surgery so that there is no pressure effect on it. Secondly, what else will you do? You have to fix the spine.
Fine.
Yes, sir.
C6 vertebra collapsed is the most dangerous thing. Patient can have paraparesis straight away. At present, he doesn't have. He has a weakness in lower limbs, but this at cervical level can cause paraparesis.
Yes,
So you need to address both things together. So how do you treat cervical spine fixation? For for metastatic disease in the cervical spine. For short of time, I will just explain you the things because you need to fix the spine and the spine is fixed anteriorly, not posteriorly. Normally, these spine surgeons,
Right.
they do it posteriorly and they just do the laminectomies and open up the spines, the spinal cord, okay? But here in the cervical area, they do it anteriorly. So once you are doing your surgeries, you're doing a total thyroidectomy, you try and fix the cervical spine in the same sitting. Okay, so they put a cage sort of a thing which they fix up the cervical spine. So cervical spine has to be fixed. You have to plan your surgery accordingly with the spine surgeon so that in a single sitting both things can be done. Okay.
yes, sir.
Secondly, about bone metastasis. So thyroid surgeries with bone metastasis, what precautions will you take at the time of surgery? So these metastases are very vascular metastases. You must remember. So at the time of surgery, there could be increased chance of bleeding from there. So you have to have adequate blood products ready with you. Many times, if it is a very vascular one, sometimes you do pre-op embolization of these lesions and try to reduce vascularity before you are taking them for spine fixation. Correct?
Yes.
You
Yes.
have to have these things in mind. You have to plan your surgery before taking patient in.
Yes, sir.
Hmm? Third thing, which is more important for bone metastasis. So how do you manage these patients? So she's got weakness in the lower limbs. She's got multiple pressures. So pressures are on the lumbar vertebra as well as on the cervical vertebra. So you fix cervical vertebra. What will you do for the lumbar metastasis?
Palliative RT for the bone meds, sir.
Yes. So if the spine is unstable, again remember, so if the spine is unstable, if your vertebra is destroyed, then you need to fix the vertebra surgically. So it's important whom will you call? Will you call for radiation or will you call a spine surgeon to fix the spine? So if it's an unstable vertebra with a compression on the nerve, with the weakness impending, it is better to do a surgical fixation
Yes.
that will give you immediate decompression of the nerve and fixation of the spine because spine is weight bearing area. So you need to remember these facts while you are planning treatment for a metastatic disease.
Yes.
Correct?
Yes, sir.
So this is what needs to be done, a total thyroidectomy, fixation of the spine and decompression of the spinal canal cord. Then you can go for your radioiodine treatment.
Yes.
Biphosphonates can be given in thyroid metastatic lesions to the spine, but you have to be very careful when you're giving biphosphonates because most of these patients after surgery, many times they are hypoparathyroid. The calcium levels are low, so you have to be sure that the calciums are maintained. before you give, and the kidney function is normal, before you give any biphosphonate therapies for your patients.
Yes.
And secondly, yes, you have to do a radioiodine. What precautions will you give do while giving radioiodine? Will you like to have an early radioiodine, or you will wait for 3 weeks till the TSH rises, then you do a radioiodine?
In this patient, I have a early radioiodine, sir.
So you have to give recombinant TSH and take them for RAI treatment. The problem is that you have given a contrast scan, iodinated contrast was given. So the effectiveness of the radioiodine reduces if you have an iodinated contrast given beforehand. You'll have to wait for 6 to 8 weeks for the effect of contrast, iodinated contrast to go away. So the efficacy of RAI is less. Is there any role of external radiotherapy now in this patient?
Sir, to palliate the pain, if there is any severe pain, we can go.
Palliative, as a palliative RT can be given, sir, in this patient.
So in these particular sites where you have a compressive symptoms, where you've decompressed it, again, you can add external radiation to control the disease over there and give symptomatic relief to your patients. Okay, so external radiation also has a role in managing particularly bone metastasis. Okay.
Yes.
Yes.
So Dr. Krishnamurthy, would like to add anything on
No,
to it?
no. I think it's a very interesting case, as you rightly said. I think the sequence of events is important, and thyroidectomy can be done in the same setting, since it's a C6 lesion. I think it's a challenging case, requires multimodality treatment. You'll have to closely work with your neurosurgeon, get it done in one shot, and then possibly add on to with radioiodine and external beam radiation therapy. Really well managed, Dr. Nair. I think it's a very complicated case and really well managed.
So there is one question in the Q&A section. Why total thyroidectomy in metastatic thyroid?
There are certain
No,
cancers, even with metastasis, we have to ablate, we have to remove the primary tumor, like RCC and thyroid cancers.
RCC, why you are getting RCC here?
For giving radioiodine,
When
sir,
you're
it is a
dealing
definite
with thyroid
indication.
cancer, I think you're better to stick with that. Otherwise, I think sometimes the discussion can go a little haywire. So I think just stick to the index cancer that we are treating. Yeah.
So how does radioiodine work? So if you are giving if you have a thyroid tissue remnant, you just said in the previous case that if you have done a hemithyroidectomy, you can't give RAI because the RAI will just go and concentrate in the thyroid. It
Yes.
will not go to the metastatic site. For RAI to go to the metastatic site, you have to remove thyroid.
Yes,
Correct?
sir.
Right.
So that's why you do a total thyroidectomy in these patients.
Yes.
Right. Yep.
I think we are running
Yeah. I
short of
think we can.
time.
Yeah, we can sort of discuss.
I think we can wind up the case. Excellent presentation, Dr. Mukaram. Good. You've tried, both of you, Arul and you.
Yeah.
Did a good job.
So we'll move on to the expert talk by Dr. Arvind Krishnamurthy. Thank you so much, Rohit sir, for providing your great cases and rare cases. Was a great learning experience. Thank you so much for joining. Yeah.
Thank you, ma'am. Thank you.
Ziba, should I start
Yes, you
sharing?
can. Yes, sir. You can
Yes.
share the screen, sir.
Okay, fine.
I now request all the panelists to mute their mics.
Yep. Is it okay? Am the slide fully seen?
Yes, sir.
Yeah. I think must thank the leadership of the IASO for giving me the opportunity to speak on thyroid cancers. And of course, incidentally, what has happened now is that we have an ATA 2025 guideline also recently released. So I was just wondering as to how to give this expert talk. So much of loads of information which is there. But then I actually kept this presentation with the view that a lot of you all are giving your exams. So I thought that I will keep it contemporary, also incorporate some of the advances that have happened in the ATA guidelines. So this thus will be the layout of my talk, and we will try to sort of cover each one as it comes. First, the epidemiology. By and large, I think we will be discussing only about well-differentiated thyroid cancers. Anaplastic and medullary are subsequently an important topic. We can discuss that later. We find that it's a surgeon-managed disease in the past, and radioiodine was given as appropriate. But now our understanding of thyroid cancers is different. We now think that this cancer is also a hot tumor. Hot tumor in the sense that a lot of molecular markers are expressed by these cancers. That gives rooms for a lot of systemic advances, especially in the space of progressive refractory, radioiodine refractory, multi-metastatic disease. So if you see the epidemiology, thyroid cancer incidence was increasing worldwide. In fact, it was a 300% increase in the last 30 years until 2015. From 2015 onwards, we have seen for the first time a decline in the incidence of thyroid cancers. But fortunately, the mortality from thyroid cancers has remained relatively stable or possibly has steadily declined. And this is, mind you, only for the low risk cancers. For the high risk cancers, you find a 1% increase in mortality, and there is room for improvement in some of the high risk cancers. So why did it increase by 300% over the last 30 years is possibly because of two things: epidemic of a overdiagnosis, or is it actually an epidemic of the actual disease increase per se? When we talk about overdiagnosis, we mean the diagnosis of cancer that would not result in death if we had left it in situ. And thyroid cancer is a classic example of an epidemic of overdiagnosis because we diagnose a lot of incidentalomas by ultrasound, CT, and PET-CT. But studies have shown that it is not just the increase because of the papillary microcarcinomas or the incidentalomas. There is also an increase in the epidemic of the actual disease per se as well. So there is a two components for this increase. And why has it decreased? Since 2015, of course, the ATA guidelines have been progressively coming, 2009, 15, and now 25. A larger nodule size threshold for evaluation, and some of you rightly said that less than a centimeter, they say don't evaluate. Higher ultrasound suspicion for a biopsy based on the thyroid score, and they say that your FNA threshold has decreased by 20% ever since the inception of the thyroids. There is also the concept of NIFT-TP, which was earlier considered to be a cancer, and now they say not a cancer, and that is the reason why the decrease in thyroid cancer has been happening. So much so that a US Preventive Service Task Force actually says don't screen for thyroid cancer. If you want to read about the perils of overdiagnosis, read about the South Korean story and a part of it which we have published earlier as well. And this is, of course, the criteria for thyroids and size threshold for biopsies. A little busy slide, but I must say that less than a centimeter, irrespective of the thyroids, don't evaluate. If it's a thyroids 4, more than a centimeter and a half, and if it's a thyroids 3, you evaluate if it is more than a couple and a half centimeters. Again, with regards to thyroid incidentalomas, and this is actually a major component of the increase in the incidence of thyroid cancers, more commonly detected by ultrasound. 20 to 46%, and some studies say around 67% incidental diagnosis of thyroid nodules just by the use of ultrasound. But mind you, although the incidence of detection of the nodules is high, the incidence of malignancy in ultrasound detected thyroid nodules is less than 10%. Vis-a-vis, in a PET-CT scan, there is a less than 5% incidence of nodules, and this is global literature. But mind you, if there is a nodule detected in a PET-CT, you have a higher chance of malignancy, and that is close to around 33%. So 1 in 3 of the PET detected nodules is more likely to be malignant. We did a study much earlier in 2020 we actually looked at all our PET CT scans in a particular year and discovered close to around 290 incidentalomas. What we found that the rate of incidence of thyroid cancers with a proven diagnosis was only 10% in our series, vis-a-vis 33% in the earlier series. And this is because of the fact that we, being a tertiary cancer center, evaluated only about 14% of the PET associated incidental neoplasm. The reason is, for most of the causes for ordering a PET scan was because of advanced thyroid, advanced lung cancers, advanced hematolymphoid malignancies, in which the treatment of the index malignancy took precedence over evaluation of a thyroid nodule. So in real world oncological practice, whenever you do PET CT or whenever you are ordering PET CT for advanced malignancies, the tendency is more to treat that particular cancer and not evaluate more of the PET associated incidental neoplasms, as was there in our case. So that is something that you must keep in mind while evaluation of the PET associated nodules. Again, principles of evaluation, a lot of ATA 2025 is based on what is called as a data framework. It's nothing, diagnosis, assessment, treatment, and assessment subsequently. So all the aspects of thyroid cancers which were there in 2015 guideline are now cumulatively put in what is called as a data framework for each of the scenarios there. The risk factors, and we did briefly allude to childhood radiation exposure to ionizing radiation, and obesity also incidentally has been found to be positively associated with thyroid cancers. And Dr. Arul elegantly said about all the syndromic association of familial non-medullary thyroid cancers, in which a germline mutation is actually mandated. By and large, for the evaluation, and we did briefly discuss this, ultrasound, and majority of our radiologists are using the TIRADS, which is very good. FNAC by Bethesda, and this is pretty straightforward, and I would urge you all to sort of read about TIRADS and read about Bethesda as well. I'm not covering molecular classification for Bethesda 3 and 4, but because that's a topic in itself. I must say that, as rightly was discussed in our discussion, cross-sectional imaging, ideally you do it for advanced or invasive disease, primary disease with gross ET or bulky adenopathy. Routine diagnosis or routine evaluation by a FDG PET CT is actually not recommended. Coming to the overview of surgical management, and this is a little part of history which I feel that is very important for all of us to know. Prior to 1850, the mortality was 40%. Mortality was 40%, and this is possibly because of hemorrhage and asphyxia. So much so, the French Academy said that you should be banning thyroid cancer surgery. Samuel Gross went a step ahead, saying that it's horrible butchery and no honest or sensible surgeon would ever engage in doing a thyroid cancer surgery. But what has happened is we have learned and unlearned a lot of things. Bill Roth, the father of thyroid surgery, he brought down the mortality to 8.3% and Cocker to about 0.18% in their series of 2000 thyroid cancers. So now surgery of thyroid cancer is not much about mortality except for the really, really aggressive radioactive refractory ones, which I'll come to in the later part of the talk. It is more about decreasing morbidity. There are some good prognosis thyroid cancers where an active surveillance and ablation is there. What is more discussed nowadays is the surgical approach, and with minimally invasive and endoscopic and robotic approaches coming in the flavor. Where does that fall? Also, we are increasingly using a lot of technology in surgery across the board, across all cancers. In thyroid, this is no different. We have the near infrared fluorescence, the use of ICG, which is called NIRAF. We also use a lot of intraoperative nerve monitoring in selected cases. And I thought that I should focus a little bit on the surgical approaches, little bit on IONM and NIRAF. With regards to extent of thyroidectomy, not much has changed ever since the 2015 guidelines, except for the fact that they have said that less than 2 centimeters, you can surely go for a lobectomy or a hemithyroidectomy, and less than 4 in selected cases, you can do for a lobectomy or a hemithyroidectomy. Again, with regards to surgical approaches, you have three approaches. The classical transcervical approach, which still is the gold standard for advanced complex cases like tracheal resections and gross extrathyroidal extension, multiple nodes with extranodal. But I believe some centers are trying to use robotics for such cancers as well. The endoscopic approaches, and more commonly use the robotic, and the transcervical has lost favor. A lot of transaxillary approaches and the transoral thyroidectomy approaches are there. I must say that despite doing excellent surgery, we do at times land with occasional bad scars, and the patients actually push us to do one of these robotic approaches. With regards to the robotic thyroidectomy evidences, I must say that there is definitely longer operative times, but definitely better cosmetic outcomes, no significant decrease or difference in the complication rates, and an equivalent short-term outcomes. And I've given you the references of a couple of publications from Kim in 2018 and then subsequently Chen in 2021 in the head and neck. So there is evidence to suggest that the cosmetic outcomes are excellent, no difference in complications, and equivalent short-term outcomes. So the final take on robotic approaches is useful for early stage thyroid cancers. If you're really experienced, you can sort of push the limit and go for advanced stages. It's about prioritizing cosmetics. A lot of patients do ask, and I was quite surprised, and even in our practice, a lot of patients do ask and inquire about the other minimally invasive approaches. Robotic approaches is a reasonable option in such patients. Of course, the caveat is, as for any surgery, you really require some experience, high volume centers, and now there is a definition also about more than 25 to 50 thyroidectomies. If your center is performing, it's a high volume center. But I must say that open thyroidectomy still remains a preferred option in very high risk and advanced cases. So these are the approaches in transaxillary, and you get reasonably good outcomes. We have also done occasional patient of TORT, transoral robotic thyroidectomy. I must say that some of these patients are extremely satisfied with the cosmetic outcomes for these patients. The other thing is about the use of NIRAF for the parathyroid identification in thyroid cancers. And the parathyroids have a unique property called as autofluorescence, and that can be used to detect the presence of the glands in thyroid cancers. You have two systems of NIRAFs. One is the probe-based systems and another is the camera-based systems. You could additionally administer ICG and combine it with the NIRAF for better fluorescence imaging to check the viability of these particular glands. A lot of evidences, and there is one evidences by COSAT, which is published in the JAMA a couple of months ago in July 2025. It says that the use of NIRAF has consistently improved the parathyroid detection rate. In fact, they say that if you use near-infrared fluorescence, 15 to 20% higher visualization of the parathyroids as compared to visualization by the naked eye. Definitely, there seems to be benefit for hypocalcemia reduction, more so in observational studies, but in randomized controlled trials, unfortunately, the benefit of hypocalcemia reduction was not that much. So definitely you're able to visualize more glands by using near infrared fluorescence, but then in randomized controlled trials, the benefit has not translated into a benefit in terms of hypocalcemia as well. And this is you can also identify parathyroids ex vivo. For example, you remove the gland and you focus your beam on the removed thyroid gland, and sometimes, as in this case, you can see a parathyroid gland, so you sort of take it and auto transplant it. This is an additional benefit of the autofluorescence as well. So in the real world, where do you use NIRAF? Ideally, all cases, but definitely so in the complex and redo surgeries. But mind you, there are some potential false positives. FDA has actually approved only two systems, the flow beam and the PTI. Of course, it comes with a lot of costs as well, and you really require some amount of surgical training to perform the NIRAF. Other thing is with regards to nerve monitoring. And mind you, the nerve monitoring is not just for the recurrent laryngeal nerve, it's also for the external branch of the superior laryngeal nerve. And it sorts of aims to reduce the complications. Again, when it comes to evidences for the IONM, I must say it's mixed. You had a Cochrane review back in 2019, 5 trials, no advantage. You now have more than 8 meta-analysis. the latest meta-analysis by G, which says that IONM in reoperative thyroid surgeries, and this, mind you, this was only in reoperative thyroid surgeries. It says the IONM did benefit, but the benefit was more pronounced in temporary palsy. The rates of permanent palsy was not decreased. Again, there are two ways of doing the IONM. You could do a continuous monitor or you could do the intermediate monitor. And a couple of meta-analysis by Pisano and Sun said the continuous IONM is slightly better. So in real world, where do you fit the IONM? Some people say use it in all cases so that you get the practice, but definitely I must say that you definitely use it in recurrent and complex cases. But one thing is it should augment rather than circumvent the need for a meticulous surgical technique. So you must do your naked eye visualization of the nerve and then use the IONM, maybe the continuous type if you have that, for better yield or better injury rates in your particular series. Again, when it comes to thyroid cancers, you can sort of put it in three different buckets. Some I would call some of the majority of the cancers are good cancers, about 85 to 90% of them. A 20-year survival rate of around 99%. And I would certainly give you little glimpses of what is the so-called good cancers. We'll go into slightly the bad cancers and the ugly cancers to the end of the talk. A lot of good histology. There is a WHO 2022 classification. I was urge you all to read through that. NIFT TP classification is there in 2016 by Nikorov. And then you have three other cancers, tumors of uncertain malignant potential, hyalinizing trabecular tumors, and these are all diagnosed pathologically. These are excellent prognosis tumors, a very, very low malignant potential for these tumors. Unfortunately, you have to do surgery to get to the diagnosis. Again, one thing that is coming up in a big way, especially in many international meetings, is the active surveillance for a favorable micropapillary carcinomas T1A N0M0. There seems to be a heavy global research surge on this topic, but the adoption in various countries seems to be much low. It is more so in Japan and Korea. Certain centers, high volume centers, like for example, the MSK have their own publication, the adoption is picking up. I must say it's a shared decision making process. A lot of experienced thyroid surgeons in India also, through personal discussions, know that a lot of them are keeping some of the cancers under active surveillance. Low progression rates, there is only a 3 to 10% progression over 5 to 10 years, and hardly any impact on mortality. And the active surveillance for the low-risk micropapillary has been endorsed by nearly all the guidelines, be it ATA, Korean, NCCN, or the ESMO or the Japanese guidelines. Again, one thing is about the pediatric thyroid cancers, and somebody did make a mention that the presentation, a lot of these cancers tend to have very advanced presentation, at times a very dramatic presentation. In fact, in our series, we found that 11 kids had actually upfront lung metastasis. Younger the age, more the lung metastasis. 3 out of 4 of our patients who are younger than 10 years had got lung metastasis. A fifth of them were actually visualized on a chest X-ray. But then 91% of these patients had a complete response with only one dose of radioactive iodine ablation. Results are extremely gratifying in our 67% of our patient series. What we found is that more than 71% were node positive, 50% had extranodal extension, yet the 10-year survival in our cohort was a 100%. We did have about 16.5 recurrences, but we could salvage almost all the recurrences. So pediatric thyroid cancers are a one spectrum of excellent survivals in some of these cancers. Now shifting gears to what is the locally advanced ones, and these are the ones that most of us treat by being virtue of being some tertiary care centers. Thyroid cancers coming out of the skin, soft tissue, extract muscles, recurrent laryngeal nerve, trachea, great vessels, esophagus, larynx, or in various combinations. They can come, and these numbers are from the classical McCaffrey publication in 1994. Again, we have had our experience of doing tracheal resections. Difficult for me to go through entire principles. You have the Shin classification, Shin 3 and 4, you tend to do circumferential resections. Shin 1, you can shave. Shin 2, possibly also shave. And these are certain principles of tracheal resections. We've published our data, no 30-day mortality, 175-month follow-up. we have a 10-year survival of close to 50% and a 15-year survival of around 35%. So even tracheal resections in well-selected patients doing by the classical technique and some of the principles I had alluded to earlier is really worthwhile and gives decent survival for some of your patients. And our publication is quoted in the meta-analysis that was published in 2021. We have done again esophagectomies, we have done superior vena cava thrombectomies, we've hacked clavicles, we've hacked ribs, sternum, a lot of these things as a part of metastatectomies for thyroid cancers. Generally, adjuvant treatment, radioactive ablation, and we briefly discussed that during our case presentation. It could be either remnant, whereas ablation, where the normal, presumably the benign tissue is ablated. It could be adjuvant for subclinical tissue, or in a known metastatic disease, it could be treatment of that particular disease. Again, what's important is that you suppress your patients on thyroxine, and the dose of suppression would be based on the risk stratification of these patients. Higher the risk, higher the dose of suppression as we have given. A lot of the follow-up will happen based on ultrasound, serum thyroglobulin and serothyroglobulin antibody. A lot of you all must know the changes that have happened in TNM8. I've just briefly highlighted them. Again, the important cutoff is age, which we briefly discussed, 45 to 55. And there are various other forms in which we have T3A, T3B, T1A, T1B, and I'm sure that most of you all can sort of go through your TNMs to sort of note the changes that have happened in the TNM classification. The other thing, of course, there's not much change from the ATF 2015 to the 2025 guideline with regards to the risk of recurrence, except for the fact that there is an entity called as oncocytic thyroid cancers whose prognosis seems to be a little worse. Again, all the cancers, the PTC, the FTC, and the OTCs, they have been risk stratified into various buckets of low risk, intermediate risk, and high risk of recurrences rates. And this is important for us to sort of understand where the trajectory of your patient is going, and based on that you would sort of determine the level of thyroid suppression and the intensity of follow-up for these patients. Again, you risk stratify some of your patients into excellent, intermediate, biochemical incomplete, and structural responses, and again you assess them using the data framework for your management. It's very difficult for me in this short time to go through the entire concept of the dynamic risk stratification. And finally, to the last part of the talk of ugly thyroid cancers, and these are the ones that are really radioactive refractory thyroid cancers, 10 to 15% of them. A lot of them may have molecular alterations like the BRAF V600E and the TERT mutation. Mind you, despite that, they have a life expectancy of close to 3 to 6 years. So the worst of the thyroid cancers also would live at least 3 to 6 years, if not more. And again, about quarter of them to half of them would express BRAF V600E and other mutations. We did a mutation study of BRAF V600E in our population of patients, and we find that close to 40% of our conventional PTCs did express the BRAF V600E. It was a significant predictor of adverse outcomes, and we proposed a risk stratified approach based on age, again prognostic, BRAF V600E and ETE, and we feel that there is a extremely high therapeutic potential for these. Again, as I said, thyroid tumors are hot tumors, and there are a lot of advances that have happened over the years, especially in the radioactive iodine refractory space. 2 TKIs have been approved, and these were based on earlier publications. In fact, the SELECT and the DECISION trials, more than 10 years old. Sorafenib and lenvatinib, and the lenvatinib seems to be the go-to drug, reasonably effective agents, but potentially severe dose-limiting adverse effects. So they must be used cautiously and judiciously. And mind you, you have a PFS advantage, but not an OS advantage. In the second line, how you go about treating these patients, again, you can give them cabozantinib based on the COSMIC trial data. And again, you try to do an NGS for some of these patients in the second line. Try to see if they have expressed some of these mutations, and you have the targeted therapies as has been quoted in this. I don't really want to go too much into the details, but I think you all can read through this. And as I said, sometimes some of the well-differentiated cancers de-differentiate and go into anaplastic thyroid cancers. And there is a recent ASCO publication of using Keytruda, that's pembrolizumab, in combination with daflufinib and trametinib, based on Mark Zafirio's publication from the MD Anderson. Very occasionally, you can use some of these therapies as neoadjuvant approaches, but these are certain very, very selective case series and case reports, seeing the impressive results that have occurred in the radioactive refractory series. And we have had some success by using some of these TKIs in the neoadjuvant therapy to improve resections and avoid upfront initial mutilating surgeries for this. And again, this is a work in progress and a growing body of scientific evidence. So I must conclude, I know that I've covered a lot of ground. I must say that surgery still remains the mainstay for the treatment of thyroid cancers. What was once considered horrible butchery, now we have a supreme triumph for the surgeon. Very, very gratifying to manage. I think if you want to treat some cancers, I think a lot of you can choose thyroid cancers because, as I said, the survivals are excellent. In 20-year survivals close to 99% in the advanced ones. Even in the radioactive refractory ones, you have survivals of patients of up to 3 to 6 years and a lot of progress being happening. But a lot of nuances are happening in the way in which we treat the adjuvant treatment, especially radioactive in patients, and the way in which we use the systemic therapy for these patients. As I said, these are hot tumors, essentially enormous potential for genomic testing and actionable oncogenic drivers for this. I think I will stop my presentation here, and I would be happy to take any questions. Thank you again, IASO leadership at Sigma, for the opportunity to give some glimpses. I know it's been pretty exhaustive, but I try to throw some lights here and there about the management of thyroid cancers, especially the well-differentiated ones. Thank you once again.
Yeah, so I can see there are, since there are no more questions in the chat box, and you have pretty much covered very comprehensively the topic, a lot of things that we left behind in the discussion with the candidates, very well covered. Candidates, do you have any questions, any doubts that you want to clear? So for the benefit of all the members who have joined today, we will be coming back on the 23rd of this month, which is 2 weeks from now, on with Mastery of Surgery, which is a video demonstration of surgeries based on thyroid cancer. And October 14th would be again a masterclass. The topic will be announced shortly. I now invite our IASO Secretary, Dr. Rudra Acharya, to provide the word of thanks and close this session.
Yeah, I think it was very nicely covered, and students did also well. Arvind and Rohit, thank you very much for joining and taking out time. I think this is a very common cancer, so all postgraduates need to be 100% correct, not to have anything. And very great talk by Arvind, Dr. Saradi is telling. So thank you very much. And I thank the Indo-American team for every time making all the hard work to connect all the people. Thank you very much.
Thank you, sir. Thank you all for joining tonight. Thank you, sir, for Rohit, sir, for providing such a great presentation, and Arvind, sir, for covering everything again. Wish you all very good night. Thank you for joining.